So welcome, Dr. Wade Weigel, for joining us to this exclusive one-to-one interview, and thank you very much for joining us for an insightful conversation as part of our Behind the Mask series. You are an accomplished anesthesiologist based in Seattle, Washington, and you're affiliated with the prestigious Virginia Mason Medical Center with over 20 years of experience in practice. And as a co-chair of the ASA task force, you are playing a crucial role in shaping the field of anesthesiology and patient safety. So that's why we are really excited having you here today and to share your wealth of knowledge and insight with our audience. It's crucial to note that this interview is not product related. Instead, it aims to delve into clinical practice, guideline recommendations for neuromuscular reversal agents, professional practice changes, and ways to enhance patient safety. So again, we are very excited having you here with us today. And with any further ado, let's get to my first question, Dr. Weidel. So first question, can you provide us an overview of the risks and implications of residual paralysis following the administration of neuromuscular reversal agents?
Sure. Well, first of all, thank you very much for having me. I appreciate the opportunity to be able to talk about neuromuscular blocker management. Implications of residual paralysis. So I'm going to start with talking about the fact that the ASA guidelines don't actually talk much about patient outcomes. And the reason for that is that the studies are done in different ways, using different technologies, different cutoffs, and different patient outcomes, such that we weren't really able to consolidate all that information into basically a meta-analysis, which is how we came up with most of our recommendations, was with a very rigorous statistical analysis like that. That being said, there are plenty of studies out there showing the different implications of residual paralysis. In particular, I've looked at 26 studies from 1997 to 2022. They do use different technologies. Over half of them use acceleromyography. They also have a few that use mechanomyography, electromyography, and one also that uses kinesiomyography. So what do they show? There is implication, or there are findings, that length of stay, both PACU and hospital length of stay, are prolonged with residual paralysis. There's also studies that show that general recovery is worsened. Patients feel weak, they have double vision, they have trouble tracking visually, so that their overall sense of quality of recovery is diminished. And then we get into the pulmonary issues, and from things like forced vital capacity being reduced, peak expiratory flow being reduced, and then pharyngeal tone is reduced, airway collapse is more prominent, upper airway obstruction also more prominent. This leads to more need for airway support. Atelectasis can occur, as well as aspiration. And then we get into the hypoxic respiratory drive, which is actually reduced with residual paralysis. There's also hypoxia, which leads to more oxygen support, more critical respiratory events. This can lead to PACU intubations, which are more common in the setting of residual paralysis. And then respiratory failure, postoperative complications and events. And then, postoperative pulmonary complications has been fairly commonly studied and shown to be more common when people have residual paralysis. And I should say that even though there's varying levels of trend-to-4 ratio cutoff, that 0.9 is probably the most common, certainly with the newer studies. That's the cutoff that they.
Thank you very much for that information. I have a few questions related to that a little bit later on. So how can clinicians mitigate these risks?
Well, it's pretty simple, actually, and that's what the guidelines are all about, is how do we reduce residual paralysis. So I refer to recommendation number 3, which I think is probably the only one that we really need, which states, when using quantitative monitoring, we recommend confirming trend-to-4 ratio greater than 0 or equal to 0.9 before extubation. All the other guidelines are ways to support that primary goal, which is really what we've been trying to do here at Virginia Mason too.
Absolutely. Talking about the guidelines, what are the guidelines, concordant recommendations related to the selection of an appropriate neuromuscular reversal agent? And how do these recommendations contribute to improved patient outcomes from your point of view and from based on these guidelines?
Sure. So far I've discussed the ASA guidelines. I'm going to also talk about the European guidelines, which came out about a month before the American. And so for both of those guidelines, the recommendation for deep block, which is train of four count of 0 and post-tetanic greater than or equal to 1, moderate block, which is train of four count 1 to 3, and shallow block, which is train of four count of 4, but a train of four ratio less than 0.4. So for all three of those levels of blockade, sugammadex is the recommended reversal agent. For minimal block, which is train of four count of 4, train of four ratio greater than 0.4, then neostigmine is a reasonable alternative for that. Importantly, when you look at the two different guidelines, the ASA and the European guidelines, there seems to be maybe a little discrepancy there, because the ASA guidelines say train of four ratio of 0.4 is when you can use neostigmine, or consider it, and the European guidelines say train of four ratio of 0.2 is when you can consider neostigmine. Importantly to understand, though, is that both of the guidelines are more similar than different, because the ASA guidelines specifically say in the context of quantitative monitoring, when you can actually measure their train of four ratio, that it is considered acceptable to try reversal with neostigmine at deeper blocks. Okay, so, and we're thinking mainly shallow block, but even deeper blocks than that, as long as you get to that third recommendation, right? The train of four ratio of 0.9, that is the goal. And then in the European guidelines, when they say train of four ratio of 0.2, they actually specify that's in the context of quantitative monitoring. So you see how the two guidelines, even when they seem to differ, they're actually more similar than they are different. It's pretty remarkable, honestly, how these two guidelines were produced independently, and yet it looked like we were copying each other when you read the overlapping components of the guidelines.
Yeah, absolutely. Yeah, so these guidelines you have shared are valuable resources that we will certainly consider also here in Europe and follow to ensure the maximum safety and well-being of our patients. I have another question for you, Dr. Weigel. Could you share insights of the professional practice change initiative with quantitative neuromuscular monitoring and its impact on clinical practice?
At our institution, it was in 2019, we decided that we were going to commit to having all of our patients monitored with quantitative monitors, the neuromuscular blocker and depth monitored quantitatively, and that we were going to assure that the train of four ratio was greater than or equal to 0.9 before extubation, which needed to be documented on the chart. So there's a few different components there, not only the monitoring, not only the attainment, but also the documentation. So if any one of those is not met, then of course we are not happy with our results. So in order to attain this, we started in October 2019, and we put monitors in all the rooms. We were able to choose those monitors based on provider feedback. So before that time, we had various different technologies introduced to our providers, and we looked at their feedback and we decided on what they would consider to be the acceptable monitors technology that would work within the practice. In December 2019, we also made a couple videos and we launched those videos. So the idea there was that we didn't want anybody to have an excuse such as, I don't know how to use this stuff, therefore that's why I'm not using it. So the the videos were going through all the different menus of the monitors, how to place the monitor, really a practical approach to, if you're going to be using these to monitor neuromuscular blockade, here's how you do it. And then in June of 2020, in order to facilitate real-time reminders, we actually have electronic reminders in our electronic medical record. So as the case is going on, if you've given reversal, there'll be a reminder that comes up on the anesthesia record that says you need to verify and document train of four ratio before the case is completed, before extubation. And then I think probably even more importantly, we did a lot of education in the beginning, which was lectures and talking in general. But throughout this process, it got really personal, the communications, where I would email people and say, look, I've been checking charts and I noticed that this, that, and the other chart of yours does not have documentation. Can you explain to me, did I miss it? or why it's not there. And then it would hopefully facilitate a conversation, and that would help improve their care. Also, maybe improve their understanding about, number one, that this was important, but number two, that it was important to the department and that we were really watching. So with all these, and actually a few more, I haven't mentioned everything, but there are a few more steps that we took as well. But we went from basically 0 to 2% documentation, which was in 2016. We looked at before our intervention, and then in 2020 we were documenting in over 93% of our cases transfer ratio greater than or equal to 0.9.
So I observed that one of the key findings of the Virginia Mason Professional Practice Change Initiative study was a 42% reduction in postoperative complications. So what has been the impact of such a significant reduction?
Well, I think what's important about things like post-op pulmonary complications is that the anesthesiologist doesn't see that. So it doesn't really have much of an impact on their care unless you give them feedback. So you have to let them know in their institution that when we provide better neuromuscular blocker management practice and when we verify transfer ratio greater than 0.9, that our patients are doing better at a time that we may not even see them. So they've left our care, they're on the floor, they're in the ICU, and they're avoiding pulmonary complications. So I think that's pretty important in this because we have a lot of resistance to neuromuscular blocker management change. And some of that is people are seemingly think that there's not an issue, that we're making it up, and that's why we have to lean on the data, which, as I've alluded to before, there's many studies showing deleterious patient effects, but also when it gets really, really focused on your institution and the current and or future state, if you've made the change, then I think that resonates a lot with the providers, because now they know that it is them. It's not just other institutions, other practitioners, other versions of neuromuscular blocker management.
So you were mentioning before the 90% train of 4. So the importance of achieving documented train of 4 ratios greater than or equal to 90% in all patients has been emphasized for improved patient outcomes. So can you elaborate on the significance of this practice and its implications for reducing residual paralysis?
Yeah, well, first of all, I think I'll take a step back as well, maybe back and forward, to say that was in 2020 that we had that train of 4 ratio greater than 0.9 in 93% of the cases. I actually just looked at this last month and went back through. We now have a more robust electronics system, so I can do this electronically rather than I had to look through 2,000 charts individually before. But now I can just pull this data. And it was very encouraging that of our 120 providers, the average documentation was 95%. So, or I shouldn't say the average. Yeah, the average compliance with documentation of train of 4 ratio greater than 90% was 95% of the cases. And then with that, again, going back to my emphasis on individual communication, I actually just sent out 120 personalized emails, one to every single provider attending CRNAs, residents, and fellows, that gave them their specific numbers and said, this is how you've done in the last year and in the last quarter. So we get a global plus current practice idea of how things are going. And it was nice sending those out because it was more of a celebration than anything else to say, look, this is not normal. We're doing better than probably anywhere else in the world. And it's our culture shift that's making this possible. Some of the changes as far as using quantitative monitoring, in particular, I think for reversal, is that we do tend to use more sugammadex now than we did in the past. And I have been one to advocate for using neostigmine when appropriate, even been accused of what they call sugamma shaming, meaning, if somebody uses sugammadex inappropriately, I say, look, that's a pretty expensive drug. Use it when you need it. I have no qualms. If the surgeon's asking for very deep neuromuscular blockade and you need to use it at the end, then that's absolutely the drug to be used. But when it's not necessary, or when there's an opportunity to reverse with the less expensive drug, you should try neostigmine. And that was actually included in those emails as well that I sent out, which was interesting because I was working with a CRNA last week who got the email, who was talking to me about the email, who was trying to follow the advice by using more neostigmine, and she actually reversed the patient at a transport count of 1 with neostigmine. And thinking about all the studies and everything, I said, well, that's just not going to work, but let's wait and see. And sure enough, after the surgeons got done throwing a couple extra stitches and closing all their wounds, the patient reversed fully to 103%, which is acceleromyography. And so what that reminds me of is the fact that we just can't tell from patient to patient. There's a lot of interpatient variability, and it can go both ways. Some people actually have a train to four ratio of 0.4 or 5 or 6. You give neostigmine and it takes 20 minutes to reverse. And sometimes you give that same reversal at train to four count of, like this was 1, and in 20 minutes the patient's fully reversed. So it's why there's no magic bullet, and it really needs to be monitored properly. Because the last thing too is that if the patient reverses spontaneously, we don't give any drug. There's no need to give a reversal agent to attain the goal train to four ratio that you have already attained.
So we are coming to our last question, but so Savant, our company strives to eliminate residual neuromuscular block by 2025. So what strategies, advancements do you recommend for managing and preventing residual paralysis?
Well, I think the first thing is to lean on all of the advice that's coming out of the various societies around the world. It has been pretty universal that when a national society comes out with neuromuscular blocker guidelines, that the emphasis is on quantitative monitoring. It's not on any specific drug, but it's on quantitative monitoring. And I've already mentioned the European and American societies, but we also have Canada, France, United Kingdom, Australia, Spain, and probably some other national societies who have come out in favor of quantitative monitoring. So to me, that resonates very well with practitioners to say this is what the expert panels, and it's not just your country, it's all around the world, and it's consistent, and we're all saying the same thing. So there must be something there, and you need to listen. So that's the first thing, and that kind of helps get through the educational. It maybe drives it home more that we're not making this up, that it's actually real, and it's been vetted through, like I said, multiple different anesthesiologists and societies. Once you get to that and people are convinced that they need to use quantitative monitoring, I think that it's really important to make sure those monitors themselves are functional, reliable, and able to be used in flow. So as people are taking care of patients amidst their busy day, that this can be part of the flow of their care, and that this will enhance, obviously patient care, but also not detract significantly from administration of that care or efficient administration of that care. We need to be cost conscious, at least over here, about the reversal use. We still try to limit sugammadex. And as I've mentioned, there are also opportunities here now that we can avoid giving any drug. If a patient doesn't need the drug, that's avoiding exposure to an unnecessary medication. So I think that should be kept in mind. In our institution, about 10% of our patients reverse spontaneously. I think depending on how judicious you are with the neuromuscular blocker administration, and or how long it takes for the surgeons to close, what their requirements are for depth of block during the surgery, all those things are going to play a part. But really, with really careful use of the neuromuscular blocking agents, you can 1 in 10 of your patients at least. I think Dr. Thielen's has got to maybe 20% or so in his institution, where you don't have to give any reversal agent. And I think that's a win for the patient as well. And then when it comes to implementing this in your individual department, I think that one of the things that we did that was really important was that we gave the equipment choice to the practitioners. We asked them what they wanted to use. We gave them a few different choices. We talked about cost, both acquisition cost as well as disposables cost. And we talked about the limitations, the different types of values you're going to get, also the limitations with regard to tucked hands, which can be a problem with acceleromyography, though we do a lot of tucked hands with acceleromyography. You can get around that as well. And then, as we did in 2019, you make sure that there's equipment in every single room, that is in and of itself not enough. You have to make sure that that equipment is functional, that you have a troubleshooting plan in place, that you have a way to replace parts efficiently, you have backup monitors, and then I think also critical is the user support. So we have anesthesia techs here who are really, really helpful. And then also anybody here, they know they can call me, but also as people become more comfortable with the technology, you have more and more content experts who will help each other. We next looking at ways to, like I mentioned before, make sure this is efficient within the workflow. So sometimes we actually put the monitors on the patient in the admission bay. And then when the monitors have the automated modes, the repeats, when it toggles from 3-4 ratio to count to PTC and back, very helpful for the clinician to have all these depths of block presented to them without them having to do anything. And then something we don't have here, but I think is really, really helpful, is the EMR integration. So when all that information gathered by the monitor is automatically fed into your anesthesia record, that's one less step that you have to do in order to get this stuff documented on your patient's chart. I've already talked about feedback, so I think the more personal, the better. And then if you can get patient outcomes for your particular institution, I think that's extremely powerful for the people who are working in that place.
So when I hear you, I really think and believe that our goal by eliminating residual neuromuscular block by 2025 is achievable. Not sure if you think that is the same way I think, but hearing you, there is a possibility, right?
Yeah, well, when you say that, it makes me smile because when I met Dr. Thielen, he was the co-chair with me at the ASA task force. I think it was 5 years ago, he said his goal was to eliminate residual paralysis before he could retire. So when you say 2025, I think, well, gosh, that gives Stefan the opportunity to retire when he's still young and can enjoy it. So I hope it happens. I've been looking forward to that. I was very naive. I thought in 2010, when I became very interested in this topic, I thought we'd have it fixed by 2011. We're clearly way off track for that. But I do think there's a lot of momentum. I think the monitors out there are getting better and better. There's more choices, that the clinicians are hearing the messages because it's very, very consistent and it's been around for a while. And I think once all this momentum builds up, it's going to happen hopefully fairly quickly, though I don't know. I hope for 2025. I really do. I think that's a good aspirational goal.